Today we'll examine West Nile virus through a One Health lens, the framework that links animal, human, and environmental health. WNV is the most common mosquito-borne disease in the continental United States and is a textbook example of a zoonotic, vector-borne pathogen that no single discipline can manage alone. As future veterinarians, you sit at a critical node of the system. You protect equine patients, recognize sentinel events in birds and horses, counsel clients on prevention, and feed surveillance networks that protect people. Keep that interface in mind throughout. Nile virus is a small, enveloped, positive-sense, single-stranded RNA flavivirus, antigenically related to St. Louis encephalitis and Japanese encephalitis viruses, which matters for serologic cross-reactivity and diagnosis. It was first isolated in 1937 in Uganda and emerged in the Western Hemisphere in 1999 in New York City, where it was detected almost simultaneously in crows, zoobirds, horses, and people. Within a few years, it spread across all 48 contiguous states. It infects more than 250 bird species. Let's talk about the enzootic cycle. The virus is maintained between mosquitoes and birds, and mammals are incidental hosts. This single fact drives everything about its epidemiology and control. Health is an integrated approach recognizing that the health of people, animals, and ecosystems is linked and interdependent. WNV is a near-perfect case study. On the animal side, while birds are the amplifying reservoir and horses are the most affected domestic species. On the human side, people are dead-end hosts, yet roughly 1 in 150 infections progresses to severe neuroinvasive disease with lasting sequelae. On the environmental side, the whole system is governed by mosquito ecology, standing water, temperature, and rainfall. And climate change is pushing the virus into new regions and longer seasons. The practical message for you: surveillance and prevention only work when veterinary, medical, and environmental sectors share information. Is the core concept of our entire talk. In nature, WNV is maintained in an enzootic cycle between Culex mosquitoes and wild birds. Mosquitoes acquire the virus by feeding on a viremic bird. After about a week of extrinsic incubation, they transmit it to the next bird. Amplification peaks in late summer when mosquito and bird populations are high. So-called bridge vectors then feed on mammals, spilling the virus over to horses and humans. The critical point: horses and humans are dead-end hosts. They develop viremia too low and too brief to reinfect mosquitoes. That means WNV is not transmitted horse to horse, horse to human, or human to human under normal circumstances, and you cannot catch it from handling an infected animal. Control, therefore, targets the mosquito-bird cycle, not the dead-end host. Competence varies enormously. Wild birds, especially passerines like American robins, crows, and jays, are the amplifying reservoir. Corvids are so susceptible that mortality can approach 100%, which is why dead crow surveillance became an early warning tool. Among mammals, horses dominate the clinical picture. They account for roughly 97% of reported non-human mammalian cases. But note the nuance. Only about 10% of infected horses develop clinical disease, and of those, case fatality is around a third. Dogs and cats are readily infected, but very rarely become ill, usually only the very young, very old, or immunocompromised. The important point is this: all of these mammals are dead-end hosts, so their importance is clinical and as sentinels, not as sources of onward transmission. Signs are highly variable, which makes WNV a diagnostic challenge. In horses, the hallmark is neurologic, ataxia and hind limb weakness, fine fasciculations, especially around the muzzle and face, behavioral changes, hypersensitivity to touch and sound, and cranial nerve signs such as muzzle deviation or a head tilt. Recumbency, a horse that goes down and cannot rise, markedly worsens prognosis and often drives a euthanasia decision. Birds show incoordination, head tilt, tremors, and blindness. An infection is frequently fatal in corvids and raptors. Dogs, cats, and most people are subclinical or mildly ill. Critically, none of these signs are specific to WNV, so you must rule out rabies, always on the list for any neurologic case, along with EPM, EHV1 myeloencephalopathy, and the other arboviral encephalitis. This starts by ruling out other neurologic diseases, then confirming with serology. The IgM-capture ELISA on serum or CSF is the most reliable antemortem test in horses because IgM indicates recent infection. It can detect the virus from about 6 days up to 2 months after infection. For birds and for postmortem work, RT-PCR, virus isolation, and immunohistochemistry on brain, heart, and kidney are preferred. Be cautious interpreting serology because flaviviruses cross-react and viremia is short. There is no antiviral. Management is purely supportive. NSAIDs, IV fluids, and nursing with special attention to protecting recumbent horses from secondary injury. Prognosis is encouraging overall. Many horses recover, though roughly 30% relapse within a week or so, and some keep residual deficits. Finally, WNV is nationally notifiable. Reporting confirmed cases feeds the surveillance system that protects the whole community. Prevention is where veterinarians have the biggest impact. The equine WNV vaccine is classified as a core vaccine by the AAEP. Every horse should receive it annually with semi-annual boosters in high-risk or long mosquito season areas. Because horses are dead-end hosts that never transmit the virus onward, vaccinating a horse protects that horse, not people directly. What protects people is the shared mosquito control and the sentinel value of equine cases, not the equine vaccine itself. There is still no licensed human vaccine, so human protection rests on the environmental tier of prevention and on surveillance, not on horse vaccination. The second pillar is vector control, which does protect horses and people at once because it targets their common vector, removing standing water where culex breed, stable horses during peak dawn and dusk mosquito activity, and use approved repellents. Never DEET on animals as it's toxic to them. The payoff is real. U.S. equine cases peaked above 15,000 in 2002 and fell dramatically afterward, thanks to vaccine uptake, mosquito control, and growing immunity in the bird reservoir. That decline is a concrete example of One Health prevention working. Surveillance is the connective tissue of One Health, and it relies on two complementary streams. Environmental surveillance monitors mosquito pools, dead birds, and sentinel animals to predict human risk before the first human case appears. Epidemiological surveillance, anchored by the National ArboNet system, aggregates human, equine, mosquito, dead bird, and sentinel data to quantify and map virus activity. Veterinarians feed both streams. A single equine case is often the earliest sign that virus activity is rising in a region, so reporting it protects people. Beyond reporting, your role is to counsel clients on vaccination and mosquito control, advise safe handling of dead birds, gloves and double bagging, never bare hands, and act as a trusted community communicator about zoonotic risk. This is the heart of the veterinarian's role as One Health messengers. The material to a representative case. This is a teaching scenario, not a specific patient. A 12-year-old unvaccinated quarter horse gelding presents in mid-September from a pasture beside a pond. Over 48 hours, the owner notes a low-grade fever, muzzle twitching, hind limb ataxia, and hypersensitivity to touch. Let's think about this together. The season and the unvaccinated status raised WNV on the differential immediately, but we need to first rule out rabies for safety, along with EPM and EHV1. An IgM-capture ELISA on serum confirms WNV. Management is supportive, NSAIDs, IV fluids, and sling-assisted nursing to protect the horse as it weakens. This horse recovered over about 3 weeks, and the case was reported to public health. So what does this teach us? Respect seasonality, ask about vaccination status, prioritize differentials, and remember that reporting closes the One Health loop. Consolidate into our 5 key takeaways. First, WNV is a bird mosquito flavivirus. Horses and humans are incidental dead-end hosts that don't transmit onward. Second, among animals, horses carry the clinical burden, about 97% of non-human mammalian cases, with neurologic disease and roughly a third case fatality in symptomatic horses. Third, confirm with an IgM-capture ELISA and treat supportively because there is no antiviral, and always rule out rabies. Fourth, prevention works. The core equine vaccine plus mosquito control drove cases down dramatically after the 2002 peak. Fifth, and most importantly for your future role, veterinarians are One Health sentinels. Through reporting, client counseling, and surveillance, you connect animal, human, and environmental health. If you remember nothing else, please take away these 5 key takeaways. These are the sources behind today's talk. If you found this information helpful, please like and subscribe for more. Thanks, and I'll see you next time.